Cysts are extremely common. A simple renal cyst, just an isolated renal cyst, is benign. They will always be benign. They don't need to be followed. They don't need repeat imaging. But not all cysts are simple. And obviously there's some conditions that can cause some significant proliferation of cysts, which is really what we're going to be focusing on today. So, compare and contrast the type of renal cysts, determine their respective clinical implications and management. So I just told you the simple renal cysts are benign and you don't have to do anything about it. That's true. So, by virtue of how the kidneys function, practically everyone will have at least one cyst in their kidneys by the time they shuffle free of this mortal coil. All right. So a simple renal cyst forms as a result of a weak spot forming in the tubules, and ultrafiltrate of urine starts to accumulate in that area and it ends up dilating out, forming a cyst. Okay. It's just think of it like if you curb check a tire really hard and damage the radial belting of the tire and it gets a bleb on the side. That's what happens in the formation of a simple renal cyst. And I bet if we put an ultrasound on the flank of every person in this room, we'd find a couple, because they're just extremely common. And like I said, eventually every single one of you will probably have one at some point in your life. Okay. Most radiologists, when they read ultrasounds and CT scans, and to some degree MRIs as well, will comment on the appearance of cysts, and they'll tell you this is a simple solitary cyst. Sometimes they'll even use what's called the Bosniak grading system. So Bosniak was a radiologist. He created a grading system more to help summarize imaging findings than to. His intention was not to create a system that gave you any sort of prognosis, like long term, about whether or not a cyst was, had malignant potential. But as it turns out, the grading system does work that way. You're not going to be tested on it, but just for academic purposes and for your own clinical application later on, a Bosniak 1 is a simple cyst. A Bosniak 2 is a not quite so simple cyst. A Bosniak 3 has about a 30 to 50% chance of having some badness in it, and a Bosniak 4 has about a 70% chance of it being malignant. So if you ever see a radiology read that actually describes a Bosniak score, what you really need to worry about is 3s and 4s. Now, Bosniak described his grading system before CT scan had been invented. So he was working off of ultrasound. After CT was invented, they added a 5th score. You know how radiologists like to hedge their bets, right? They'll say things like recommend clinical correlation, or I'm not sure. The grade that they put in the middle was grade 2F. 2F means, well, it's not quite a 2, it's not quite a 3, I'm not sure. If you see a 2F, that is the one instance where you need to get follow-up imaging. About 6 months. Image it again, make sure it hasn't changed. Okay. So, as I mentioned, they're just cavities in the kidney that are filled with fluid or semi-solid material. Most of the time it's just ultrafiltrate of urine. Semi-solid material, you'll often see reads on imaging, whether it's an ultrasound or an MRI or a CT scan, that says proteinaceous material. That's the way that that's determined on ultrasound is just there's a difference in the density of the fluid. So the more dense the fluid, it'll look different because the ultrasound waves don't pass through it at the same rate. Blood is also more dense. Usually they can differentiate between proteinaceous material and blood. Blood's a little bit more concerning. And occasionally they'll actually be solid material. That's when you start talking about your Bosniak 3s and your Bosniak 4s. 50% of individuals over the age of 50 will have a renal cyst. So, renal cysts, technically speaking, are considered to be a form of renal mass because it's an object that's not supposed to be there, even though it's super common. But you don't have to do anything about it. Now, the caveat to that is if you end up with a cyst that is so large that it starts to impinge on other organs in the abdominal cavity, then that's a problem. We might actually do something about that. The biggest single cyst that I've ever seen in my career was the size of a football. And we decorticated that cyst because it was coming off the upper pole of the kidney and it was actually pushing on the diaphragm. And the patient was dyspneic at baseline just because she couldn't expand her lungs all the way. But most of the time they're asymptomatic and they're found incidentally. You do imaging for some other reason, or you'll have somebody who has some degradation in their renal function. You get a renal ultrasound as part of your workup for them. You find cysts. The cysts, a simple isolated renal cyst, or even if you look at the kidney in the bottom right-hand corner where there's one on one pole, one in the mid pole, and one at the other pole, those aren't causing problems in the patient's renal function. Now, on physical exam, it's usually unremarkable because, again, they're usually found incidentally. They're not found as a result of some physical exam finding or symptoms that are being caused unless they get particularly large. They can get infected. If they do, that's a problem. Now you basically turned a cyst into an abscess. And sometimes they need to be drained for that reason. But just a simple cyst sitting there hanging out doing nothing isn't a problem. Now, why do we have a couple of boxers going at it here? Excuse me, going at it here on the slide. If a cyst is large enough and somebody receives a significant blow to their flank, they can rupture. As long as they're not bleeding significantly, there's nothing you need to do about it, but they can. And so you can end up with somebody who has the same type of blunt trauma that you might see to a kidney that doesn't have cysts in it if somebody was in a, say, like a bad car accident, or somebody wailed on them with a baseball bat, and you might have to treat that like you would any other trauma. So this is what they look like on imaging. So in the upper image, you've got a simple renal cyst on ultrasound. Generally, they'll measure them. What you're looking for is for the cyst to have a uniform, smooth wall. You don't want to see septations, although having a couple of minor septations, thin, fine walls within the cyst, not a problem. That's going to be like your Bosniak 2. If the walls are thickened, if they're irregular, if there appears to be like a solid mass that's sort of sticking off the wall into the lumen of the cyst, that raises your concern. Now, the cysts that you see here on the bottom right hand, these are simple as well, but they're larger. Are they necessarily something that needs to be intervened upon? No. But they could potentially get to the point that they start causing symptoms. And they don't even necessarily have to impinge on other organs. Occasionally you'll get cysts that are so big and in such a location that they actually start to interfere with the ability of the kidney to drain. So you can get what's called a peripelvic cyst, which instead of arising from the posterior wall of the kidney, they arise from the medial wall right up next to the renal pelvis. Oftentimes those are misinterpreted on imaging as hydronephrosis because they're right up against the renal pelvis. And so that can make things a little bit trickier for you diagnostically, especially if you're dealing with a patient who has some increase in their GFR, increase in their creatinine, or excuse, decrease in their GFR, increase in their creatinine. You may wonder, well, is that a cyst or is that hydro? And that's something you learn to discern with experience. So as I mentioned, they're anechoic normally, unless they've got something more dense inside them like proteinaceous fluid or blood. The walls are generally sharply demarcated. Why do you think there's, well, it says on the slide. I was going to say, why do you think there's an enhanced back wall? It's throughput. So if the back wall, so that the ultrasound probe is up here, right? This is where the ultrasound waves are coming into the body, and it doesn't project very well, but you may notice that this wall is a little bit darker than this wall. So this one's darker than this one. And that's because the ultrasound waves speed changes when it goes from passing through the solid tissue of the kidney to hitting the fluid. And then when it gets to the other side and some of it gets reflected back, the ultrasound probe is able to detect that difference in ultrasound wave speed, and it gives you a brighter intensity. So as I've already mentioned, smooth thin wall, sharply demarcated. If it's a contrasted study, it should not enhance. If it enhances, if the radiologist is actually able to measure an increase in Hounsfield units in the cyst when the contrast goes through, which also requires you to have a non-contrast phase to be able to detect that difference, then you get more concerned about it. Because if it enhances, that means it's vascular, and cysts should not be vascular. If it doesn't look simple, send them to urology. We'll determine whether or not surgical exploration is necessary or not. Oftentimes we'll look at those patients and say, no, we don't need to do anything about this. But if it is a Bosniak 3, a Bosniak 4, especially if it's graded as a Bosniak 3 or 4 on CT, we're probably going to recommend that they have surgery. And in that case, it's not going to be decortication. We're not going to open the cyst and drain it off. We're going to treat it like a tumor. And if we can, we'll just remove the whole cyst. Sometimes they're located in places like this one in particular on the image here. It's very medial, and it's also very endophytic, so it doesn't stick out from the kidney. It's mostly in the kidney. This might not be something that we can get after to just shell it out. We might have to take the whole kidney in the event that we were concerned that was malignant. So, are these kidneys normal?
No.
Are these simple cysts?
No. Maybe.
They might be. The cysts themselves might be simple, but when you have cysts in this number, and look at the hands of the person holding them. Are these kidneys of normal size? No. So what do you think's going on with this patient? Polycystic kidney disease. Now it's impossible to know if it's autosomal dominant, autosomal recessive just by looking at it. But yeah, these are polycystic kidneys. So why are these polycystic kidneys about to go in a bucket?
They're no longer in the body?
They're no longer in the body. Very good. So where else are you going to put them? In a bucket. Great. The answer is correct. So do you have to take the kidneys out of somebody who has polycystic kidney disease? Let's say their kidneys have completely failed and they need a transplant. Do you have to take their native kidneys out? No. In fact, you usually don't. So I know I've shared this with some of you already, but if you're doing a kidney transplant, where do transplant kidneys go? Where do we put them in? Do we put them up here?
Lower, right?
If the answer is no, why not? Why don't we put transplant kidneys in the retroperitoneum? There's a reason. So it does have to do with anatomy. It's not structural support, however. Blood flow. So the kidneys derive their blood supply from the renal artery, correct? Where does the ureter get its blood supply? Let me ask the question a different way. Does the ureter get its blood supply from more than one location? Yes. So the proximal ureter, the proximal third, derives its blood supply from the renal vasculature. So the renal artery provides the majority of the blood supply to the proximal third of the ureter. The distal third of the ureter gets its blood supply from the perivesical arteries. So it gets its blood supply from the bladder. And then the middle third of the ureter gets its blood supply from penetrating vessels that come through the psoas muscle and from the adventitia around it. So if you took a transplant kidney from a living donor, took the entire ureter all the way down to the bladder, and then tried to put that kidney in somebody's retroperitoneum, what level of success do you think you're going to have in reconnecting the blood supply to the middle and distal thirds of the ureter? None. We're talking really, really small vessels, like so small that you can't even do microvascular repairs on them. I mean, it's one, you're working inside the belly. You're not going to get a microscope in there, and they're just too small. You can't put them together. So if you try to put a transplant kidney in somebody's retroperitoneum, the distal 2/3 of the ureter are just going to die. So then you've got a kidney sitting up in somebody's retroperitoneum that, I mean, it's filtering blood, but the urine's just dumping into their belly. So transplant kidneys are put into the pelvis. So we make an incision, usually a fan and steel incision, so lateral off to one side. Think about like half of a C-section incision. And the kidney is placed right in the retroperitoneum, or excuse me, not in the retroperitoneum, in the pelvis. And the vasculature is connected to the iliacs. And then the ureter is just plugged into the dome of the bladder. And that proximal third, which is all the length you need because you're putting the kidney down here, gets its blood supply from the renal artery that's now connected to the iliac. And so you don't have to go up to take these out. Now, these, as we've already mentioned, are quite large. So I can't tell you for sure why this person had a bilateral nephrectomy, but reasons might include that these kidneys were so big that they were actually starting to impinge on other organs because they're tight. Or maybe they got infected. So if you have a polycystic kidney that gets infected, the likelihood that you're going to be able to clear that infection is pretty low. For one thing, the blood supply is probably already compromised, and cysts, excuse me, don't get very good penetration of antibiotics. And so if they're chronically infected, if they've got chronic pyelonephritis in these polycystic kidneys, then you take them out. I would argue, though, that based on the size and based on the fact that they took both of them, probably it was just because they were so large that they were just running out of real estate. All right, so autosomal dominant polycystic kidney disease. It's the most common inherited kidney disease, and about 50% of patients will have end-stage renal disease by age 60. Now, based on which genetic mutation they have, their kidneys may not necessarily get to be as big as the ones we saw on the previous slide, and they may not necessarily lose as much renal function. As you can see, if it's the PKD2 mutation, the progression is slower. And longer life expectancy, having polycystic kidneys in and of itself isn't what kills them, right? It's the absence of functioning kidneys. So if you give them a transplant, they're going to have a normal life expectancy as long as they take care of the transplant kidney. And as you can see, autosomal recessive polycystic kidney disease, 1 in 40,000 births, so it's pretty rare. And it's almost always bilateral because it's a genetic condition. So if there's a defect in the patient's genes, it's not going to just affect one side. You can have acquired polycystic kidneys, but they don't look like this. You're talking about a normal looking kidney that just has multiple cysts in it. And you can see here on the left, there's a relatively normal kidney with a fairly large simple cyst on top. Autosomal recessive polycystic kidney disease, they usually don't get big. The cysts that form an autosomal recessive polycystic kidney disease are usually very small, but they're just as proliferative as they are in autosomal dominant. So the parenchyma is being overtaken by cysts in the same percentage. They're just smaller, they don't get quite as big, and the kidneys don't enlarge like that. So when they get real big, they can actually be visible and palpable from the outside. You have to be real careful when you're doing a physical exam on a patient with polycystic kidney disease. Do you think that these are more prone to rupture? Do you think you have to hit them like a boxer, land in a body blow, to rupture a cyst when they're this big and they're that close to the surface?
No.
No. So you got to be real gentle when you're palpating the abdomen in patients that have autosomal dominant polycystic kidney disease. So you can see the head's up this way, feet down here. That's a big kidney. So again, when it gets big, they may present with abdominal or flank pain. These kidneys may have a problem with recurrent urinary tract infections, pyelonephritis. They can also develop nephrolithiasis. Your treatment options for patients with nephrolithiasis and polycystic kidney disease is somewhat limited, relatively speaking. For example, you can't do extracorporeal shockwave lithotripsy on somebody with polycystic kidney disease because you'll just rupture the cysts. If you do extracorporeal shockwave lithotripsy, or ESWL for short, on a normal kidney, those patients end up developing hematuria after all the shocks that they receive, because it does do damage to the parenchyma, the shock waves traveling through the kidney to break up the stone. So imagine what it does to a polycystic kidney. Hypertension is a big problem in patients with polycystic kidney disease. And obviously there's a very strong family history because it is genetic. Now remember I said that the largest cyst that I've ever seen, largest simple cyst I've ever seen, was the size of a football. That's not a simple cyst, but that's a big kidney. Normal kidneys are about like this. Not anywhere near that size. So, they may have hematuria and proteinuria on their urinalysis. If they've got a problem with chronic infections, they may have pyuria or bacteriuria, and they have progressive loss of concentrating ability. That's part of what happens when that leads them to end-stage renal disease. They can't concentrate their urine anymore, so they're just dumping free water. The bigger the kidney, the lower the GFR, and ultrasound is the best way to image these patients, and it's also how you follow them to see if their kidneys are growing, if they're developing more cysts. But a negative ultrasound doesn't necessarily rule out autosomal dominant polycystic kidney disease. So if they're below the age of 30 and they have a family history, if it's something you're concerned about, CT or MRI is going to be better for you for confirming the diagnosis. So you can see here, this, like, can you even tell that there's a kidney? Like, if you didn't know that this was a renal ultrasound, looking at that upper right picture, would you even be able to say, oh, yeah, that's definitely a polycystic kidney. That looks like a kidney with a bunch of cysts in it. No, it just looks like trash, right? It's just a bunch of static, but that's what it is. And then you can see on the CT image, and this is where you can start to understand why it might be hard to confirm the diagnosis on ultrasound. So this kidney, they're both enlarged. They're not super enlarged, and the cysts are all endophytic, and there's still some fairly decent parenchyma in there as well. So CT much more helpful in this particular patient. So having cysts as you get older, as I mentioned, is normal. Everybody's going to have some. And you can see here, if they're simple cysts and they're within this age range, having greater than or more than 3, you might start to get a little bit concerned. But polycystic kidney disease, you're not talking like 3 cysts, 4 cysts, you're talking 300, 400 cysts. And again, if the ultrasound is equivocal, get a CT scan. So these are kidneys. Somewhere over here there's a liver. Right? And then you can see that, I mean, compare those 2 kidneys to those 2. Pretty marked difference, right? The parenchyma is almost completely gone. All you're really seeing there is cysts and septations. So people with polycystic kidney disease can also have hepatic cysts. So that's the liver. They can have pancreatic cysts, splenic cysts. They're at increased risk for cerebral aneurysms, aortic aneurysms, diverticula, and there's an increased risk for ectopic pregnancy in those patients as well. How do you treat it? Medically. You're going to manage their hypertension. You're going to manage whatever proteinuria they have. You want them to avoid nephrotoxic agents. Lifestyle modifications. What do we mean when we say lifestyle modifications as it pertains to these patients?
Diet?
Say again?
Diet.
I mean, so diet's going to be important, right? That's probably going to work in towards the controlling the proteinuria and the blood pressure. You want them not taking too much sodium, that sort of thing. Combatives, yes. So lifestyle modifications. You don't want them to engage in any high-impact sports. So they probably shouldn't be playing football, rugby. They shouldn't be doing skydiving. They shouldn't be doing martial arts, because they're at increased risk of significant injury from blows that wouldn't necessarily affect an otherwise normal person. And then it's very important to talk about family planning and genetic counseling in patients that you diagnose with autosomal dominant or autosomal recessive polycystic kidney disease, because there's a very good chance that they could pass it on to their children. You need to know that. As we've already talked about, they can present with pain. That can be due to infection, bleeding into the cysts. If they develop nephrolithiasis, most of the time it's bed rest, and if it's an infection, then antibiotics, right? Sometimes we do cyst decortication. More often than not, though, if they're badly symptomatic and if their renal function's already pretty much in the toilet, we'll just take the kidney out. It's not doing them any good, it's just causing them problems. Hematuria, if the cyst is in continuity with the collecting system, then you may actually see hematuria, but they can have hematuria at baseline. And they're at increased risk of renal cell carcinoma also as they get older. Questions about any of this? Nephrolithiasis, initially you're going to treat them like you treat any other patient with a kidney stone. And we'll talk more about that in the kidney stone lecture, which will be in the next block. Just know if they have stones, you're going to treat it like you would treat any other stone. Hydration and pain control, if it's small enough that they're likely to pass it. If they're not likely to pass it, then we're going to take over and manage it surgically. And then we mentioned that aneurysms are an increased problem for these patients, but there's no recommendation for screening or arteriography unless there's a positive family history or they're undergoing elective surgery where they're likely to develop perioperative hypertension. Or if they're in a high-risk profession. Do you want your pilot with autosomal dominant polycystic kidney disease to know whether or not they have an aneurysm?
Yes.
Probably. You don't want them to stroke out at 50,000 feet. That would be very bad. Not something you have to worry about in the military population because autosomal dominant polycystic kidney disease is a bar to service. But on the civilian side, you could certainly potentially have a member of an air crew that has autosomal dominant polycystic kidney disease. So renal dysfunction, as we've already mentioned, is the primary cause of mortality. 50% undergo some sort of renal replacement therapy by the age of 60. So what does that mean? Well, that means maybe they get a transplant, maybe they go on dialysis, maybe they're on continuous renal replacement therapy. And then again, to maintain these patients, same thing. Avoid nephrotoxins, get a renal ultrasound annually or more frequently if something changes in their presentation. You want them to avoid anything that's going to elevate their blood pressure and avoid contact sports. So, memorize this. Don't memorize this. Don't do that. Just for your reference. All right, so medullary sponge kidney. This is another condition that causes cysts to form. It is not autosomal dominant or autosomal recessive polycystic kidney disease. It's its own condition. It's relatively benign and it's usually present at birth. But because we don't do renal ultrasounds as part of an annual workup for anybody who doesn't have a reason to have a renal ultrasound, it's usually not diagnosed until someone's older. And usually it's an incidental finding. It's not done necessarily because there's something wrong with their kidneys. Maybe you have somebody who comes in with right upper quadrant pain, they get an ultrasound to evaluate them for gallstones, and they look at that right kidney and go, oh, well, that doesn't look normal. It has a very characteristic Swiss cheese appearance. And as you can see, it's an autosomal dominant condition. So this is not the same kidney. These are two images that are laid next to each other just to compare and contrast for you. So in medullary sponge kidney, you're not going to have half the kidney normal, half the kidney abnormal. But you can see normal kidney on the left, and then medullary sponge kidney on the right. Aptly named because where is the spongy tissue? In the medulla, right? It's not in the cortex. So they can have a problem with recurrent calcium nephrolithiasis, and those stones actually form in that spongy tissue. It forms in the medulla. Sometimes the calcium deposits are actually like deep in the parenchyma, and they're not true stones in that they're not free in the collecting system. You can't, if you drove a ureteroscope up into their kidney and looked around in the renal pelvis, you wouldn't find anything because the stone is actually under the surface of the urothelium, in which case there's nothing to do for it. And then again, they may also have a problem with concentrating in their urine because of damage to the tubules. So this is what you might see on a plain film. So you can see that there's just calcium deposition everywhere, all along the medullary area of the kidney. And this, I mean, really kind of helps you see the kidney shadow, right? So here's the renal capsule is out laterally here. And you can see that this is where the cortex is, along the outer edge. And then the medulla has the calcium deposition in it. And if this is one of those patients that if we drove a scope up into their kidney, we probably wouldn't find anything stone-wise. So this is a contrasted CT. It's a CT urogram. You can tell because there's an excretory phase, right? Contrast is going down the ureters. And they have this very characteristic brush-like appearance where the contrast is pooling in the spongy tissue. And nephrocalcinosis is the term for calcium deposition in the parenchyma of the kidney as opposed to a stone that's in the collecting system. So nephrolithiasis, stone, nephrocalcinosis, calcification of the actual tissue of the kidney. No known therapy. Another one of those conditions where you're not, well, in this case, you're not necessarily treating the underlying condition, you're just treating the complications and the symptoms that they might develop. So they are more prone to pyelonephritis. They're not necessarily more prone to urinary tract infections. A urinary tract infection is cystitis. There's nothing abnormal about their bladder. It's really more a problem of pyelonephritis. And if they have problems with renal calculi, among other things, you're going to have them increase their fluid intake. Again, we're going to talk more about treatment of stones in another lecture. And then for hypercalciuria, you may put them on a thiazide diuretic. And again, overall good prognosis. Sometimes these patients walk through life not knowing that there's anything wrong, because it's usually an incidental finding unless they present with one of those complications. All right, acquired renal cystic disease. So I mentioned this a little bit. If you have a patient who's in renal failure for some other reason, let's say they had renovascular hypertension, wasn't diagnosed quickly, wasn't managed appropriately, they don't have access to care, whatever it is, and they end up in renal failure, and they end up on dialysis. Anyone with long-standing renal failure, and particularly patients who have been on chronic dialysis for a while, will develop multiple cysts in their kidneys, usually bilaterally, and there is potential for progression to malignancy. So patients that are on dialysis, excuse me, who are being managed appropriately are typically getting renal ultrasounds annually to make sure that their kidneys haven't had a change structurally that's concerning for malignancy. Questions about that? So these are acquired cysts. You notice that the kidneys are, I know there's nothing for scale here, but the kidneys are relatively regular size, relatively normal size, I should say. The cysts are of varying sizes. Some of them are really small, some of them are a little bit larger. But does that look anything like autosomal dominant polycystic kidney disease? It looks more like autosomal recessive, but the key differentiation here is that this is somebody who's been on dialysis for a while, and this is acquired renal disease. You wouldn't necessarily know that without the history. And if they've been on chronic dialysis, hopefully they're on a transplant list somewhere, assuming that they are candidates for transplant. And if the kidneys are problematic for the same reasons that they're problematic for somebody with polycystic kidney disease of an autosomal dominant or recessive nature, if they've got chronic infections, stones. These kidneys generally don't get large enough that they're going to start impinging on other structures. Usually, people with chronic end-stage renal disease, their kidneys usually become atrophic. So they're usually normal size or smaller, and then they can be overtaken with cysts. Questions on renal cysts? Do you want to go ahead and take a 10-minute break now while I pull up the next slide deck, or do you want to just wait and keep going and take a break in 10 minutes, 12 minutes?
Push.
Ooh. My bladder's on a timer.
Okay, so if you really want to push, this is only 19 slides. And we can just be done, and you can have the rest of the time back to yourselves into your next lecture. Sound good? Okay, we'll keep going. All right, so cancers of the upper urinary tract. I'll let you read that.
Done.
All right, so renal cell carcinoma. So we've talked a bit about renal cell carcinoma already. We've talked about predisposing risk factors, so tobacco exposure, aniline dyes, things that increase a person's risk of urothelial carcinoma, also increase risk of renal cell carcinoma. Chronic end-stage renal disease, on dialysis, autosomal dominant polycystic kidney disease. Incidence peaks in the 6th decade of life, and there is a predominance in men. And as we've talked about before, they can be associated with paraneoplastic syndromes. Anybody remember what the paraneoplastic syndrome that's most associated with renal cell carcinoma is? I mentioned it a couple of times. What do you see on lab? If you draw a metabolic panel on them, what are you going to find? Calcemia, sorry. Hypercalcemia. So they can end up with hypercalcemia, and that they don't have to have bone mets for that to happen. Now they can have visceral metastasis, other solid organ metastasis, or no metastasis at all, and have an increased calcium level on serum. Risk factors. Cigarette smoking is the only known significant environmental risk factor. But all the same questions that you would ask in regards to, like, if you see somebody with hematuria, you're going to ask all the same questions. Cigarette smoking, aniline dyes, cyclic polycarbons, if you work on a flight line, if you work in a motor pool, that sort of thing. And as we've said many times before, any hematuria in a smoker is cancer until proven otherwise. Hematuria might be gross or microscopic. I won't belabor that point. We talked about it in quite a bit of detail earlier. If the mass is large, they may have flank pain. We usually don't get to that point in the United States. People end up getting imaging for other reasons that ends up showing their kidneys. Have I told you all the story about the recruiter's, it wasn't really a recruiter's aide, he was a retired infantry guy who was working in the, working for a recruiter as a civilian here at Fort Sam, who thwarted a kidnapping at the Met station? Have I told you that story? Okay, so this is a little bit of a tangent, but it's germane, okay? It's, you'll see this, maybe not this exact situation, but you'll see this. So when I was an intern, we had a patient who was being evaluated by the urology service for an incidentally found renal mass. And the way it was found, so he was retired sergeant first class. He worked as a civilian in one of the local recruiting offices. And everybody knows where the MEP station is here on Fort Sam, just a little bit down the street. It's got the big anchors out front. So he was driving past the MEP station, or maybe he was leaving the MEP station, and he witnessed someone trying to pull a teenage girl into a vehicle on post. It was a really stupid kidnapper. But it wasn't attempted kidnapping. It wasn't just like a couple having an argument or something, get in the car. It was an actual kidnapping. And he intervened. He got the girl away from the attempted kidnapper and had positioned himself inside the driver's side door, and he's now trying to pull the kidnapper out of the vehicle to keep him from getting away. Well, the perpetrator throws the vehicle in reverse and steps on the gas, and our good Samaritan ended up getting sandwiched between the door and the car behind. He got mashed. So he ended up coming into BAMC as a trauma. Well, what do you do for a trauma patient with a significant mechanism of injury? Fast and pan scan. So they're going to get a head-to-toe CT scan with contrast. And lo and behold, among the other things that they found, which included some fractured vertebrae and ribs, they found an enhancing renal mass. So he had to wait for his traumatic injuries to heal before he could address the renal mass, because the position that you put patients in to do a radical nephrectomy is a flank position. So you put them on their sides. Well, his broken ribs were on the side opposite the renal mass, so we couldn't lay him on his broken ribs. So he had to wait a few weeks before we could take him to the operating room, which delaying a little bit in small renal cell carcinoma is not a problem. But he would not have known that he had renal cell carcinoma if he hadn't put himself in the position that he put himself in and got mashed between two cars. The point of that whole story is that the prevalence of renal cell carcinoma in the United States has gone up with improvements in imaging accuracy and access to imaging. The incidence hasn't changed. It's still the same level of incidence, but the prevalence, that is how often do we detect it, has gone up because people are getting imaging for other reasons that shows you that there's a mass. So what was the imaging modality that we talked about that was the predecessor to CT and ultrasound that was specific for looking at the kidneys? Before ultrasound. IVP. So how many people do you think were getting an IVP just at random? None. The only thing you did an IVP for was if they had something like hematuria. If you were concerned about their kidneys, then you do an IVP. But then with CT scan and ultrasound, and you do those imaging studies for other reasons, and you know, if somebody goes in for a CT of their liver, they're not just looking at the liver, they're looking at the entire abdomen. And so then you find these masses incidentally. That's the number one reason for people to be diagnosed with a renal mass, is an incidental finding because they were getting imaging for something else. But in the absence of those other reasons, in the absence of an incidental finding, flank pain or palpable abdominal mass was how people would historically present, because the mass would have to get so large that it was actually causing symptoms. A small renal mass doesn't cause any symptoms. The classic triad is flank pain, hematuria, and a palpable mass. As you can see, present in less than 5% of patients, because we find them before that anymore. Now, if you go do a medical mission in a third world country, you might actually see this, but you're probably not going to see it in the United States. Obviously, if they have advanced disease, then they may have weight loss, malaise, anorexia. And then renal cell carcinoma does like to metastasize to the lungs and the skeleton. So they may present with pulmonary symptoms if they have advanced disease. They may present with significant skeletal pain. Does everybody know why cancer that's metastatic to the bones causes pain? Has anyone talked to you about that? Why are skeletal mets so uncomfortable for patients? There's two reasons. One more painful than the other. So obviously if somebody's skeletal structure has been replaced with soft, mushy cancer tissue, is that a good weight-bearing structure?
No.
No. So they can end up with pathologic fractures. That's one cause, but that's not the most painful cause. So the reason that you hear about patients with metastatic cancer having really bad, hard to control pain, the reason they have to be on chronic narcotics like Duragesic, fentanyl patches, and methadone and things like that, is because if you get a met in the skeleton and it starts to grow under the periosteum, it starts to peel the periosteum off of the bone. And of course, nerves penetrate through the periosteum. Does that sound like it's much fun? It's not. That's what causes bone pain in metastatic cancer, regardless of what type of cancer it is. If it's metastatic to the skeleton, that's what's initially probably causing the majority of their pain. And then if they get a pathologic fracture, obviously that's not fun either. Unremarkable physical exam unless they have advanced disease. Again, these are incidentally found masses most of the time in developed nations. They can develop adenopathy. I've seen patients with metastatic renal cell carcinoma that had massive intra-abdominal adenopathy. If they have big perinephric lymph nodes, we'll try to take them. And when I say try to take them, I mean we take everything we can. Sometimes we can't get everything. But we'll take as much of the large lymph nodes as we can at surgery. Varicocele. So we'll talk more about varicoceles in the urology portion. Who can tell me what a varicocele is? Vessels where? Yes. So it's dilated vessels in the pampiniform plexus in the scrotum. Left-sided varicoceles are present in approximately 20% of the male population. That is due to your vasculature. So if you look at the venous drainage of the testicles in most males, the left gonadal vein drains into the left renal vein. The right gonadal vein drains into the vena cava. Between the vena cava and the renal vein, which one do you think is a higher pressure system? The left side. So think about, okay, I'm going to ask you to go back to basic physics. Fluid dynamics. If you compress a fluid, does the pressure go up or down? And to compress a fluid, you need something of smaller diameter, correct? That's how hydraulics work. So the left renal vein, being of a smaller diameter than the vena cava, is just by virtue of physics going to be higher pressure, which means that it puts pressure all the way down the length of the gonadal vein and can cause varicosities to form in the scrotum. I know it sounds like I'm going off on a tangent. There's a point here. Is it normal to see a right-sided varicocele? No. Now, is it possible that somebody's right gonadal vein could potentially drain into their right renal vein? Can that happen?
Yeah.
Yeah. The venous anatomy is much more variable than arterial anatomy. You'll find that arterial anatomy is pretty similar from person to person to person, but there's a lot more variation possible in venous anatomy. So yes, it can happen. But the point is, if you see somebody with a right-sided varicocele, you need to be thinking about an intra-abdominal process of some sort that is causing that to happen. And because we're talking about renal cell carcinoma, we're talking about a big renal mass on the right side. So seeing somebody with an isolated left-sided varicocele, probably normal. 20% of the male population has a left-sided varicocele that's detectable on physical exam. If you see somebody with a grade 3, which means I can see it from across the room, quite literally, I'm not exaggerating, a grade 3 varicocele is visible through the skin. So it looks like a bag of worms. So if they've got a big bag of worms looking mass on the right side of their scrotum, image their belly. Start with an ultrasound. And if you find anything, you get a CT scan. But advanced renal cell carcinoma can put pressure on the gonadal vein. Or excuse me, on the right side of the gonadal vein, irrespective of the fact that it's draining into the vena cava, it can impinge upon it. And then comorbidities that influence how we manage these patients. If they're really big and fat, we may not be able to approach their cancer in the same way that we do for somebody who's relatively slender. So for example, if they're really, really hefty, robotic surgery may not be an option. From a positioning perspective, from the perspective of the fact that you have to blow them up like a balloon to do robotic surgery just like you do with any other laparoscopic procedure. You inflate the belly with carbon dioxide, and they may not tolerate the positioning on the operating table, so they may have to have an open procedure. And if it's a big renal mass, I mean, you're talking about open them from like xiphoid all the way over to the floating ribs. Sometimes you even have to take the floating rib. We'll break open an ortho set and cut off the floating rib in order to get to the kidney if we have to go that route. So they may have hematuria. Again, this was a primary presenting symptom in the days that cancers got much more advanced before we found them. Oftentimes when it's one of those incidental findings, everything will be completely normal. It's just that we found it on an imaging study by accident. If it's advanced, they may have anemia, but they may also have erythrocytosis and polycythemia because they can end up with ectopic erythropoietin production. That's another paraneoplastic syndrome that's associated with renal cell carcinoma. And then their metabolic panel is going to be normal unless they have metastatic disease. So if they've got hepatic mets, then their liver enzymes may be elevated. If they've got bone mets, then you may see increases in their circulating calcium levels, or as a result of that paraneoplastic syndrome. CT or MRI with contrast is your gold standard imaging study. Both to confirm to you that they have a solid renal mass. So a solid renal mass that enhances with contrast is cancer, period. It's so definitive, we don't have to biopsy them. We don't need a biopsy. There is one type of renal mass that is benign, that masquerades as renal cancer, that's a solid enhancing mass called an oncocytoma, and we don't biopsy, again, because 90% of the time or greater, it's actually a malignancy, and the only way to know that an oncocytoma is an oncocytoma is to look at the entire specimen. So biopsying it doesn't do you any good. You have to actually take the whole tumor and give it to a pathologist for them to be able to tell you that it's an oncocytoma. So we just take them out. Every once in a great while, you'll have a patient that you do opt for a biopsy on. So part of the reason that we don't biopsy renal masses, in addition to the fact that 90% of the time or greater they're malignant, is that there have been case reports in the past of doing percutaneous needle biopsies of renal masses that have actually seeded the needle track. And now you've just given that person metastatic renal cell carcinoma. So again, it's anecdotal case reports, but it's enough of a pucker factor inducing possibility that we just don't biopsy them. Unless you have somebody who's really old or really frail for some reason, bad protoplasm, lots of comorbidities that you don't think they're going to tolerate surgery, then you might do a renal biopsy in that case to determine whether or not you need to do some other less invasive intervention. So you don't use radiation for renal cell carcinoma because it just doesn't respond to it. It just doesn't. But you can do things like percutaneous cryotherapy. You can put a cryoprobe into the mass and freeze it. That's an option for somebody that can't have definitive surgical management. That's a reason that you might do a renal biopsy. But most of the time that we don't. Most of the time we don't. And then the CT is also going to tell you about extrarenal spread, lymphadenopathy, and we always get either a chest X-ray or a CT in the chest for staging purposes to make sure that they don't have lung mets that haven't manifested with clinical symptoms yet. So here's your non-contrast phase, upper left, and then arterial phase. You can see that the mass here lights up, and then on a delayed phase, it's still enhancing with contrast. So that's what they're looking for. That's a enhancing solid renal mass. Now this one is sort of exophytic. It sticks out a little bit. It's lateral-ish, not quite as posterior as we'd like it to be for it to be a real chip shot for a partial, but it's in a favorable position to where you could potentially just shell out the tumor and leave the rest of the kidney behind, which is what we try to do nowadays. Anything we can do to preserve nephrons, we do. If we can't, if we have to take the whole kidney, we do. But if we can just take the tumor, we just take the tumor. I've already said it, solid renal mass is a renal cell carcinoma until proven otherwise. There are multiple subtypes. I'm not going to ask you to differentiate between the subtypes. Just know that clear cell renal cell carcinoma is the most common. If you find somebody with a solid renal mass, you're going to send them to urology and you're not going to worry about it anymore. You don't need to know what the final pathology results are. But just know that there are multiple subtypes of renal cell carcinoma. And then there are other solid renal masses. So renal angiomyolipomas, we can usually differentiate those from a mass concerning for cancer because of the fat content. You can differentiate between fat and non-fat on CT and MRI. We don't worry about those too much unless they get above 4 centimeters, then they're at increased risk of spontaneous hemorrhage. We also worry about them if they're smaller than that in pregnant patients, because pregnant patients have a risk of angiomyolipomas growing rapidly during pregnancy, and then they can rupture. Renal pelvis urothelial cancers, we'll talk more about that in a second. Oncocytomas, as I mentioned, are benign, but they're indistinguishable on imaging. So we take them out. 30% of oncocytomas have what's called a central scar when they bivalve it, when the pathologist cuts it in half and looks at it grossly, but only 30% of them do. So they have to actually have the whole mass to look at microscopically to make that determination that it's an oncocytoma, but they are benign. And then renal abscesses usually don't show up looking like a solid mass unless they're relatively early in development. After they've been there for a couple days, then they have a fluid cavity in the middle, which we might potentially drain if it's big enough to put a drain in. And then adrenal tumors. Refer to urology. We'll take care of getting them to an oncologist if they need one. If the tumor is confined to the kidney and they're a candidate for surgery, we're just going to take it out. And then if they end up needing follow-up with an oncologist after that, we'll take care of that referral. Nephrectomy if the tumor is too large to manage. Otherwise, if we can do a partial nephrectomy and just take the tumor, we will. Or a heminephrectomy where we take half the kidney. Radiofrequency and cryosurgical ablation, as I mentioned, are for patients that can't tolerate surgery for some reason. And then in some patients, you'll even do active surveillance. So do you necessarily need to do a cryoablation or a partial nephrectomy in a 90-year-old with hypertension and diabetes and coronary vascular disease, like a 5-centimeter aortic aneurysm? Probably not. They're probably not going to die from renal cell carcinoma. We might just watch them. Or give them a fishing pole and a ham sandwich and say, enjoy the rest of your life. Prognosis is good. Even for cancers that are locally extensive or metastatic, especially now with some of the newer recombinant antibody treatments that we have for treating metastatic renal cell carcinoma, the prognosis has improved quite a bit. Before these newer agents were discovered, the mainstay of treatment from a chemotherapy standpoint was interferon alpha, which requires an inpatient stay, and it is rough. It is rough. You're giving high-dose interferon alpha, and the patients don't tolerate it well. But it works. They have to be able to tolerate it, though. So if they're already frail for some reason, then they're not necessarily a candidate. Also, interestingly, renal cell carcinoma is one of those malignancies where even if they have metastatic disease, we'll still look at doing a nephrectomy or partial if the primary tumor is small enough. The reason for that is, in very, very rare cases, for reasons that we don't understand, removing the primary tumor can cause the metastatic disease to involute and go away. So a cytoreductive nephrectomy, where they already have metastatic disease, but we go in and take the tumor or the kidney with the tumor, occasionally has benefit in that the metastatic lesions will involute, and it also potentially makes them more receptive to chemotherapeutic agents because the tumor burden is less. Contrast that with metastatic prostate cancer. There's no such thing as a cytoreductive prostatectomy. If the cat's out of the bag in prostate cancer, the cat's out of the bag. Again, classic triad: flank pain, hematuria, palpable abdominal mass, which we don't see very often in the United States anymore, and then your paraneoplastic syndromes. So bladder cancer should really be urothelial carcinoma, right? Because the malignancy that arises from the urothelium in the bladder can arise from the urothelium anywhere in the urinary tract. We talked about that already, the collecting system of the ureters. Lynch syndrome is something that you'll probably encounter in other lectures and other classes. Lynch syndrome predisposes people to multiple types of malignancies, colon cancer being one of them, prostate cancer being one. It just increases the risk of multiple malignancies. So if we see somebody who has a history of, say, colon cancer, and then they present later on with a renal tumor, then we start going, maybe they have Lynch syndrome, then we do genetic testing. We can't really alter the disease process, but what that ends up doing for us if we determine that they have Lynch syndrome is we monitor them more closely for the development of additional cancers that are that people with Lynch syndrome are prone to. But the most common of everything you see on this list for other cancers of the urinary tract is urothelial carcinoma. Average age of diagnosis is 69. There's a male predominance, and again, smoking, cyclic amines, or excuse me, aniline dyes, cyclic hydrocarbon exposures increase the risk of urothelial carcinoma. Wilms tumor. So this is a pediatric tumor most of the time. Very, very, very rarely you can have Wilms tumor develop in adults. I've seen it twice in my career. Once in residency, and then once in a 23-year-old airman who was found incidentally to have a large renal mass. He was stationed in South Korea. They evacuated him to BAMC. They sent his imaging before they sent him. And I had just seen a patient with adult Wilms in my residency training program, recently graduated and come over from UT to BAMC as staff, and we were looking at his imaging, and I said, this looks a little bit like the adult Wilms tumor that we saw over at UT. I wonder if this is adult Wilms, and it turns out that's what it was. Wilms tumor, as you can see, most common solid renal tumor in children under the age of 15. Most of the time it's diagnosed before the age of 5, and it's almost always unilateral. Now, Wilms tumor is usually treated, at least initially, with chemotherapy. This is not one that we go immediately to surgery on. You can shrink the tumor, and Wilms tumors can be extremely large. You can see this poor child in the picture. I mean, look at his belly. We'll try to shrink them with chemotherapy if we can before we go in to take them out. Wilms tumors are extremely fragile, So there's an extremely high risk of the tumor rupturing in surgery, and you don't want to spill nephroblastoma all over the inside of the abdomen of a kid, because then you've really increased their problems. We do tend to biopsy Wilms tumors, those suspected Wilms tumors, to confirm the diagnosis in order to target that chemotherapy. Asymptomatic abdominal mass. Do you think that kid was asymptomatic? Probably not. Probably had some impingement type issues, bowel obstruction, something of that nature, just based on the size of that mass. They can have abdominal pain, hypertension. They can have hematuria as well. They may have fever. And then infrequently you'll see these other symptoms like anemia, weakness, pallor, shortness of breath, dyspnea on exertion. So this kid is getting ready to go to the operating room, and they have palpated the margins of the kidney or the tumor, depending on how you want to look at it. And you can see it's extremely large. Rarely crosses the midline. So if you see a question that is a kid with a palpable abdominal mass that doesn't cross the midline, think Wilms tumor. That's sort of a classic board question presentation and pants question. And as I mentioned, rupture of the capsule can spread the tumor. And this is another situation where you want to examine gently, just like in polycystic kidney disease, is just palpating and percussing their abdomen, you could rupture the tumor. Labs, same things you're going to get for anybody else that you're looking at from a genitourinary standpoint: urinalysis, metabolic panel, CBC. And then ultrasound initially. Again, it's a kid. So what are the things we worry about with kids when you're talking about a CT scan? There's two things I'm thinking of.
Radiation?
So I heard somebody say radiation exposure. That's one. What's the other thing?
I may not sit still.
Not staying still. So an ultrasound, relatively quick and easy. It's not scary. They don't have to lay on a table by themselves, away from their parents. MRIs take a long time. Anybody who hasn't had an MRI, I'm telling you, MRIs take a long time, depending on what you're imaging. CTs are relatively quick, but you're still talking about putting a child, probably under the age of 5, on a table in a scary room, away from their parents. Oftentimes they require sedation. So ultrasound first, and then CT or MRI to confirm. And if you're going to CT or MRI them, you're probably just going to go ahead and scan the chest as well to make sure that they don't have metastasis. Because if you're going to have to sedate them, you might as well just do it once. And then refer to urology, and typically we'll take care of the referral to peds oncology as well. I mean, you can shotgun it and put in referrals to both, but it's going to be a team effort on these kids. And then if you're not familiar with the NCCN guidelines, I highly recommend that you go to the NCCN website, nccn.org. It's free. You have to register for it, but it's free. And then you can access all of their cancer guidelines. And they have very detailed cancer guidelines for any cancer you can think of. I mean, literally everything under the sun. And the really great thing about the NCCN guidelines is they're a clearinghouse for everyone else's guidelines. So their guidelines tell you, this is what this professional organization recommends. This is what this professional organization recommends. This is what this professional organization recommends. And they put it all together in one document for whatever cancer it is you're looking for. So if you're talking about bladder cancer, prostate cancer, leukemia, whatever it is, it's a single document for that disease process, and it tells you what everyone says, from surgical intervention to conservative therapy for patients that are candidates for anything else, chemotherapy, all of it. It's a really, really high yield source. And you can see for Wilms tumor, for low risk, surgery alone is often sufficient. You might take the tumor out, and then they might get a single dose of chemotherapy afterwards to make sure everything got cleaned up. Intermediate risk. So if you've never heard the terms adjuvant and neoadjuvant in terms of chemotherapy and radiation, adjuvant means it's done after surgery. Neoadjuvant means it's done before. So if you ever hear anybody throw those terms around, well, this person needs neoadjuvant therapy. That means they need something done before they go to the operating room. And if they're really high risk, chemo first, then surgery, then potentially intraoperative chemotherapy. Occasionally they'll actually wash the abdomen, especially if they have a rupture of the tumor. And then definitely intensive postoperative chemotherapy plus or minus radiation. That's it. Questions?